So, welcome to Pathophysiology of Diabetes module. Today we'll be discussing both type 1 and type 2 diabetes. Alright, so in order to really understand how diabetes works, you must first understand what a normal person would look like. And so with a normal person, you're going to start with the pancreas. A normal person's pancreas works, so when a person eats, their digestion, their food's going to their stomach, and they're digested in the small intestine, and the small intestine releases glucose into the bloodstream. And what happens is you're going to have the products of the glucose that's released in the bloodstream is going to signal your pancreas to do one of two things. The first thing your pancreas is going to do is it's going to release something called insulin, which is a hormone that it produces. And it's going to release something called amylin. Amylin is going to tell your liver to stop producing so much sugar, because whenever you store products of digestion, they're stored in either your skeletal muscle, in your kidneys, or your liver, and you're always releasing little bits of glucose in order to feed your organs, in order to feed your brain. So as all these signalings are happening, the pancreas is releasing the insulin, and that helps to lower your blood sugar to keep it in a good normal range, normally between 60 and 100. And your amylin is, obviously working to in order to turn off the extra sugar that you're making, that you're not needing because you're eating. Now, you're always producing some amount of glucose because, like I said, you have to feed your organs, you have to feed your brain. So, normally a person's blood sugar runs about 60 to 100, and that's because you store all this and it's always releasing. In order to keep that under control, your pancreas is always also releasing insulin. And so it just it's like a check and balance system. They're keeping each other aligned. So I want to talk a little bit about the pancreas itself. The pancreas is an organ that helps with digestion. It sits underneath your rib cage. It's hidden behind your liver. It's very highly protected. It's a very small organ. And I would say about the majority of your pancreas provides digestion enzymes. So it helps to break down foods when you eat them. The tail end of your pancreas, the very small tail end, has something called the islets of Langerhans. The islets of Langerhans have something called beta cells. And your beta cells are the ones that sense when your blood sugar is rising. And they are the ones that release both the insulin and the amylin. So coming back here, the insulin acts like a key. So if this is your cell, you've got to get the digested foods into your cell. So insulin's like a key to that door, if you imagine that your cells have doors. And so if you have your insulin, it helps to open up the cell, and then the glucose goes in, it feeds the cell, it keeps that extra sugar out of your bloodstream where it shouldn't be, right? So that's kind of how it works. Now, unfortunately, with type 1 diabetes, you no longer produce any insulin at all. Type 1 diabetes is caused, they think, by an abnormality on one of your chromosomes, although they're still not 100% sure as to why it's caused. Normally, there's some type of abnormality, they believe, genetically, and then you develop a virus, and it kind of kicks your immune system into high gear. And your immune system actually attacks the beta cells of your pancreas, so the ones that are producing the insulin. So eventually it kills off all of them. You no longer are going to produce any insulin. So type 1 is characterized by absolute insulin deficiency, and that's the definition. So going back, if you don't have any insulin, if you no longer produce that, then you can't feed your cells. So I just want you to know that type 1 diabetes used to be called juvenile diabetes. You're mostly going to see it in younger kids. They say the average is about 15 years. I've been a diabetic since I was 3, and some people are developing it earlier. But you know, you can't call it juvenile diabetes anymore because there are older people that also develop it. It's very rare, but it can happen. So with your type 1s, you're going to see some certain characteristics in that group. Just get away from here really quick. So normally, with your type 1s, it's going to hit them hard. They're going to have 3 signs and symptoms that are really prominent. The first is going to be polyphagia, and that means increased hunger, because guess what? The cell's starving to death. It literally is, because there's pretty much no glucose going in the cell. They're just very hungry. And even though they got all the sugar on the outside, and their blood sugars are really high, I mean, they're going to be really high, people, they can't use it. So it will increase their hunger. They're going to have polydipsia. And what that means is increased thirst. Because if you think about all this sugar out beyond the cell where it shouldn't be, your body is trying to flush that out of there. I mean, you're so thirsty. You're trying to get rid of all that extra sugar that shouldn't be there, and you're trying to move it out of your body any way you can. So obviously, one way to get it out is to pee it out. So you're going to have polyuria. So you're trying to drink, trying to get it peed out, and unfortunately, that's not going to fix the problem. The only thing that can fix the problem for the type 1 diabetes is to go ahead and restore some insulin. So the other sign or symptom you might notice is you might get a kid that's really lethargic, very weak. You may also get some fruity smelling breath. Unfortunately, if you don't treat type 1 diabetes, it is very urgent that you treat it, because they can go into metabolic acidosis. Which is a whole other problem. Now, you don't want to bring down the blood sugar too quickly with these kids, with these people who have this. When they come to the ER presenting with these problems, you're going to give them insulin, but you're going to be careful, because when you give insulin, it drops the potassium. If you get too much insulin all at once, you're going to really drop the potassium level. Plus, they've been peeing out all this urine. They're already probably a little bit potassium depleted, and you don't want to send them into a cardiac arrhythmia or a cardiac arrest because you dropped it too quickly. You could also get some mental changes. You could get, there are a slew of problems with treating it too quickly. So just be happy if it's trending down. And you don't want the gap to close too quickly. One way you can prevent that is by giving them some dextrose in their IV fluids. I know that sounds like, why would you do that? But you, like I said, you have to be careful not to close that gap too quickly. Just make it nice and steady. So anyhow, that's your type 1 diabetes. And sure exactly what causes it. We just know that there's probably a chromosome abnormality, and we don't know if it's a certain environmental factor or if it's a certain virus. They have done studies in the past, and because they thought at one time that they had it narrowed down to a particular virus that was causing it, and it turned out to not be correct. So some people have said cow's milk, and I mean there's just a whole slew of people that think they know why, but really we don't know why at this point. But we do know that the way that you treat it is much easier than it used to be, and there's been a lot of growth as far as treatment options in the last 20 years. It's pretty amazing what you can do with it now. So yes, your people with type 1 diabetes have to be on insulin. The only other approved medication for type 1 diabetics is going to be your Similan, which mimics the amylin, and it tells your liver to stop producing all that hepatic glucose. It makes you feel a little bit fuller. You'll take that, before meals, and it'll make you decrease your insulin dose by about half. The problem with Similan is that it can cause hypoglycemia, so you have to be careful of that. But yes, the only approved therapy is going to be your insulin. You've got lots of treatment options as far as insulins go. I mean, you can be on shots, you can be on insulin pumps. That it's just a lot easier to deal with. It used to be that when you were a type 1 diabetic, that you had to eat at certain times a day. You had to eat exactly so much with each meal. The insulins were much less stable, I guess I should say, back then, and so there were a lot of hypo and hyperglycemic episodes with type 1 diabetes, and it was much more difficult to control, and there were a lot of lifestyle issues that it was just hard to live with it, and it's not like that anymore. It's just much easier, and I've seen that for myself, and I've seen that the changes, and it's pretty miraculous. Now, with our type 2s, you're running into insulin resistance. That is the common thing, because you can have a type 2 that is it's very mild, very borderline diabetes, and then you've got full-blown type 2 diabetes that requires insulin, and you stop making insulin eventually. So normally with type 2, there's about a 10-year period where you're seeing some high blood sugars, and you can get those treated. If you treat it during that 10-year period, then you can delay the onset of the full-blown type 2 diabetes. So the first line of therapy, obviously, if you catch it in the pre-diabetic phase, is going to be diet and exercise. Because if you lose a little bit, if the majority of your type 2s are going to be overweight, not all of them. Some type 2s, it's just a genetic issue, and maybe their whole family had diabetes and they're thin, and they just developed type 2 diabetes, and there's nothing they can do. But a lot of people can manage it with the diet and exercise for the first 10 years. They can really, if they lose the weight, then their pancreas doesn't have to work as hard, their blood sugars get better, and so it just preserves the life of that pancreas. The other thing that might happen if it's caught early enough in the pre-diabetic phase is they might go on a drug called metformin. And metformin is always going to be your first line of therapy for type 2 diabetic drugs. It helps your body to utilize the insulin that you already make. So it's not forcing your pancreas to make more insulin like some diabetic drugs do. It's just helping that insulin to go in, causing less insulin resistance. And so one thing I want you to know about metformin is as a nurse or a person working in the hospital, you have to be careful careful if you get a patient that's been on it and like you're going to send them down for, say, a CT scan with IV dye. That can cause, the metformin plus the IV dye can cause kidney failure. So if you must send them down, then within 48 hours afterwards, you need to bolus them with flows. Make sure that you're diluting them enough to help with the renal function. And just to keep an eye on your creatinine levels with that patient. It's very important. That's one of the reasons why people in hospitals are not on metformin. And the other reason why you might tell a patient that, you know, they're on oral meds at home and all of a sudden they're on insulin in the hospital only is because we can just control it a little bit better in the hospital that way. It's not only the test, but it just, you know, a lot of times when they're sick and they're in the hospital, then their liver produces more stress hormones, and those stress hormones cause an elevation in blood sugars. So it's just easier to treat it with the insulins, but they're not going to be on it at home. Now, eventually, unfortunately, diabetes does get worse. So they may have started off on their metformin, and eventually they might need some more, you know, oral medicines to help. And that's okay. You know, I want you to know that oral medicines, we were talking about how, like the liver, you might need something to shut that off a little bit, so it's not always putting out that hepatic glucose with your meals. There are some drugs for that. You have your Similac, you have your Beta, you have your Januvia. So that's how that drug works. Some of them are like insulin secretagogues, and they're the last line of therapy for oral meds. But they, what they do is they tell your insulin or your pancreas to produce more insulin so that you're getting more of a bolus with each meal. And then some of your medicines, they just work in other ways throughout the body. And we'll talk about the medications later on in Module 3. But just know that's kind of a little basic overview right now. So with type 2, you can run into not only resistance, but just not making enough insulin, depending on what level they are in the type 2 realm. It's amazing, and because, you can have type 2 that just looks perfectly healthy, and, their high blood sugar might be like 130 or 140, and they've got the pre-diabetes and they're doing pretty well. Or you could have a type 2 that is on like 200 units of insulin a day and their blood sugars are still high. So there are all different levels of it. And I want you to know that the majority of normal people don't really use more than about 30 units of insulin a day, according to research that I've read. It's kind of interesting that when you have patients, you're going to notice that a lot of your type 2s might require 60 to 90, 100 units of insulin a day, and that's just because of the insulin resistance issue. So, moving on here, I just wanted to talk a little bit about blood sugars. A normal person without diabetes, like I said, their blood sugar runs 60 to 100 at all times, besides when they eat. We don't want a diabetic person's blood sugar to be that low. We want it to be like 70 to 120 for safety reasons, because you don't want them to get hypoglycemic on you. So we make sure to tell our patients, if you're less than 70 in your blood sugar, go ahead and have a little snack. So, like I said, a normal person is 60 to 100. A normal person 1 hour post-eating, their blood sugar will be less than 150. And at 2 hours post-meal, their blood sugar will be less than 120. The pancreas works by secreting little tiny spurts of insulin all the time that counteract the sugar that your liver and your skeletal muscles and your kidneys are always secreting. So it keeps that balance. Now our insulins nowadays are long-acting insulins, they mimic that, your pancreas, whenever you eat, it's going to put out some more insulin for the food you eat. And, that's just how it works. Now, if you take insulin like Novolog, Humalog, regular, or a P drug, that also mimics this. Regular is a little bit different. It's not as quick acting as these other three. But you take those right before your meal, and they last no more than 4 hours and they're out of your system. So they're a little bit safer than other insulins used to be. And you're not going to have as many hypoglycemic episodes or hyperglycemic episodes on these new drugs. Now, let's talk a little bit about hypoglycemia. Hypoglycemia is an emergency. It needs to be treated right now. I've had many hypoglycemic episodes in my life, and they really don't make you feel very good, I can tell you that. If your blood sugar is less than 60, it means that you are not feeding your brain. You are going to be losing brain cells, whether you know it or not. There are some signs and symptoms of hypoglycemia, and first you might have shaking, sweating, feeling irritable, feeling really hungry all of a sudden, like your heart's racing. I know when I'm low in the middle of the night, a lot of times I'll sweat and I'll feel really hot, and that's how my husband will know that I'm low. And so, it's one of those things where if your patients are going to know anything, they need to know about hypoglycemia, because it is so very dangerous. If it gets down too low, if your blood sugar gets down in the 20s, 30s, then they can go into coma. They can even die from it if you get too low. So it must be treated quickly. Now, it used to be, because these other insulins back a long time ago, because they just were so strong and so potent, and they didn't have this, nice line like they do now. They would do this thing. In order to get somebody's blood sugar up, nurses and people, they would just make them eat. I mean, so much food, it was ridiculous. I remember drinking orange juices with just tons of sugar in it, just tons. I mean, you just pour the bag of sugar in it, and you still would be low. But it's not like that nowadays. Nowadays, what you teach your patients to do is you teach them to take a half cup of juice, and then they wait 15 minutes. And then if their blood sugar doesn't come back up after the 15 minutes, they go ahead and take another half cup of juice. They wait 15 minutes, and they just keep repeating it. Now, if it's going to be more than 2 hours to meal or something, then we'll encourage them to have just a little tiny snack with some protein in it, like some peanut butter crackers, or like a half sandwich, and I mean a little half of a meat sandwich. It doesn't have to be anything big. And of course, your diabetics, they most likely will know their body pretty well. But some things, if they don't have juice, they can have like 15 Skittles eaten quickly, 4 hard candies eaten quickly. They have little tubes of icing that they can eat quickly. So that's how you treat the hypoglycemia. Hyperglycemia, obviously, we're going to have some hyperglycemia with the diabetes. Now, they should be testing at least 4 times a day before meals and at bedtime. At bedtime, just because you want to make sure you're not low before you go to bed. diabetes yet, then their doctor might just have them test several times a week at different spots. But I know, like for me, I test both before and after meals, and before activities, and after activities, and whenever I go to bed too. So I test a lot of times a day, and it does add up cost-wise, but it's worth it to have your hemoglobin A1C in control, because for each A1C point, you're at about an 18% higher chance risk factor of getting complications, because your complications are happening from all that glucose out in your bloodstream that damages over a period of time. It damages your small blood vessels, and it causes both microvascular and macrovascular complications. So we'll get more into that in Module 4, but it's the leading cause of adult blindness, kidney failure, cardiac problems, so and stroke. And it has a big it's a very big disease. Even though these people don't feel bad, like your type 2 diabetics, they won't understand the importance to treat it, because a lot of times they just don't feel bad. At least they don't think they feel bad. But a lot of times when they do get under control, they feel better. So that's just something to know. It is the 7th leading cause of death in the United States, so I thought that was kind of interesting. And that's all for now. Join me for Module 2 and